Hi, my name is Raymond Osarogiagbon. I'm a thoracic medical oncologist, and this is
Rachel Stalemonson. I work with the real world evidence team at AstraZeneca.
yes, and we're going to be talking about Rachel's brainchild. This poster that we presented at ASCO this year, I had the honor of being invited by Rachel to participate in developing this concept, but I really want to make sure Rachel is acknowledged as the prime mover for this. So here we are talking about the real world experience with biomarker testing and guideline appropriate adjuvant therapy for non-small cell lung cancer. So the good news, of course, is we know that lung cancer is eminently curable when we identify patients who are able to undergo curative intent surgical resection. So we know that patients with anywhere from stage 1B to 3 are candidates for that. We also know that surgery by itself is often not enough. And we have traditionally given adjuvant therapy to people whose risk is deemed high enough on the basis of stage. Now, in recent years, we have clearly demonstrated that the use of adjuvant targeted therapy is important. So patients who have an EGFR mutation positive lung cancer benefit from the use of adjuvant osimertinib, for example. We also know that patients who don't have the EGFR mutation or the ALK mutation benefit from immunotherapy. So for those who test positive for PD-L1, the immunotherapy that will be given is either atezolizumab or pembrolizumab. We know that patients who test negative for PD-L1, at least according to the FDA, should not receive atezolizumab. Rather, they should get pembrolizumab. So we defined guideline concordance as if you get tested and you're EGFR positive, did you get osimertinib as part of your treatment? If you're ALK and EGFR negative, did you get immunotherapy? And if you got immunotherapy, if your PD-L1 was negative, was the immunotherapy pembrolizumab? Essentially, that's kind of how we define guideline concordance, okay? So in an analysis of the Flatiron data set, which is a real-world data set collected from institutions, predominantly non-academic institutions, in a very well-curated database. We looked at patients who underwent surgical resection, 885 such patients with early-stage non-small cell lung cancer who had surgery. This is the demographic breakdown of the patients, their baseline characteristics. What is interesting is that a surprisingly high percentage of these patients actually had a biomarker test. Essentially, we were interested in ALK, EGFR, and PD-L1. 84% of this cohort got at least one of those tests. Very pleasant surprise. But when you look to see who got biomarker testing, there were still some differences. So it looked like patients with stage 1B were the least likely to get tested. Looked like compared to white patients, black persons were less likely to be tested. But all the other usual parameters did not seem to be as much of a problem as has been described before. Then the next question was, of these patients who received biomarker testing, what kind of adjuvant therapy did they get? And here we see the main difference was that between Asian populations and others, there seemed to be a difference in the likelihood of biomarker-targeted adjuvant treatment. Getting to the sort of the bottom line, we see differences in survival, no surprise here, by stage, both overall and recurrence-free survival. But what is striking is that guideline concordance made a big difference. So patients who receive guideline concordant care, this is their survival. Patients who did not, that is their overall survival, recurrence-free survival. What is also remarkable is that when you look among the patients who receive guideline concordant adjuvant therapy, some of the differences that you expect to find, the disparities in outcomes, whether age, sex, race, and so on and so forth, seem to be narrowed or completely eliminated. So the lesson here is biomarker-directed adjuvant therapy is important to do. It narrows the gap between populations. Rachel, anything you want to tell us about this?
I think you covered it really well. I think it is great news that biomarker testing is so well embedded in the health system with such high proportion of patients receiving at least one treatment, one biomarker test. I do think that what we need to work on is ensuring guideline concordant treatment for patients. So that's the next big hurdle that we have to climb.
Bottom line, patients who have potentially curable lung cancer need to get these biomarkers tested for. Just as importantly, the test needs to be correctly interpreted so that the appropriate treatment can be given. When we achieve that, suddenly there are no differences in survival.